some housekeeping, and then provide an overview of our time together. We'll be using the mute feature on the audio line during this webinar to reduce background noise. We'll encourage your participation, and we will be taking questions at the end of all presentations. To submit a question, please click the question and answer icon located at the bottom of the Zoom window. We'll try to answer as many questions as possible when that time comes. If you would like to adjust the size of your slides, you can do so by dragging the vertical bar to the right or left between the windows. If you're experiencing technical difficulties, please send a message to our staff using the chat feature. Chat feature will be limited to attendees, so attendees can only message the host. They will not be able to message other attendees. This webinar is being recorded. In the next few days, you will receive a link to the recording and a copy of the webinar slides. Both the slides and the recording will also be available on the Foundation's website at that time. Now on to our agenda. First, we'll set the context about why this issue is important, why it's important to the Foundation, and we'll highlight some of the work that we have been doing in the last few years on the issues of behavioral health. We'll then provide an overview of problem management plus intervention, what it is, how it works, and where it's been implemented in the past. Then we'll discuss the experience implementing it in the US. And then finally, we'll open it up for questions and answers. What you see before you today, we have a fabulous group of presenters that have implemented the PM Plus intervention either in the US or in other countries. So I'm going to stop for a minute so you can kind of do a scan of the presenters. We're so thankful for their participation in this webinar and their commitment to the issue of increasing access to mental health services and expanding the behavioral health workforce here in the US. But first, I'd like to turn over the podium to my colleague, Caitlin Kenny-Walsh, Vice President of Policy and Research at the Foundation, who can walk us through why this issue is important and why it's an issue that the Foundation has paid a particular attention to. Caitlin?
Thanks, Jackie. And thanks again to all of you for joining us today. As Jackie mentioned, I just want to first orient you a little bit to the Blue Cross Blue Shield of Massachusetts Foundation. Our mission is to ensure equitable access to healthcare for all those in the Commonwealth who are economically, racially, culturally, or socially marginalized. We seek to advance this mission really in three core focus areas, which include care and coverage, access to behavioral health services, and structural racism and racial inequities in health. And really the topic of today's webinar is cross-cutting. It really hits across all three. We deliver in our work in two main arms. We have a policy and research arm and a grant making arm. And Jackie and I each respectively oversee those arms of our work. And what I'd like to do today is just sort of give you a sense of some of the work that we've done in the policy and research space that has really teed up our interest in the intervention that we'll talk through more deeply today. Our goal as a foundation is always to have synergy between our grant making arm and our policy and research arm, and really to have a constant feedback loop where what we're doing in one arm is informing the work of the other. And so I'd like to sort of set the context in the background for some of the work we did in the behavioral health space that really made it quite apparent that we needed to be thinking more specifically about short-term interventions. So what you see on this page is really just a sampling of the work that we have done over the last 5 years pertaining to access to mental health and substance use disorder services, which I will refer to as behavioral health services. And what we've tried to do is really understand the issues pertaining to need for behavioral health services and access to behavioral health services and experience delivering these services from a range of different perspectives. And what we've heard, and I won't summarize key findings from each and every one of the reports that we've summarized here, but what we've heard by and large is that there continues to be major challenges for consumers accessing the mental health and substance use disorder supports that they need in a timely way, and that those challenges are exacerbated for consumers who identify as a race or ethnicity other than non-Hispanic white. And so for example, in 2018, we conducted a survey of non-elderly adults in Massachusetts. And we learned that of those who indicated a need for mental health or substance use disorder supports or services, over 60% had difficulty finding a mental health or substance use disorder provider or getting an appointment in a timely way. Later in December 2020 through March of 2021, we fielded another survey to ask about people's experience needing and sort of seeking services for mental health and substance use disorder services. And similarly, in that time period, we learned more than a quarter of adults in Massachusetts indicated needing behavioral health care for themselves over the past 12 months, with the need disproportionately high among adults who identify as a race or ethnicity other than non-Hispanic white. And among those individuals, 26%, so of the more than 25% who indicated they have had a need, almost a quarter were unable to get the healthcare services that they needed. So again, just reflecting what we're hearing from consumers in terms of a real challenge getting services, and particularly among marginalized communities, finding a provider who's a good fit, because we know that alignment, finding a provider who looks like you, speaks your language, shares your culture, is critically important. At the same time, we also launched some work where we really learned about this issue from a provider perspective. For example, in trying to do a deeper dive on implementation of a model known as open access, which provides certain types of behavioral health or mental health supports on the same day in which they're sought, we learned that while this model has promise, there's also a key challenge underlying the ability to deliver it. And it is, again, you guessed it, the issue of workforce capacity. And this is also something we heard when we sought to understand from adult primary care providers what the needs were among their clients with respect to mental health supports. Similarly, adult primary care providers reported increasing need for support to address underlying mental health, anxiety, depression concerns, and challenges both seeking timely referrals to care for those patients and being able on their own to provide timely care to people in the way that was needed. So if you turn to the next slide, please, we realized the underlying theme in all of this work was really about workforce. The challenge being that we have insufficient behavioral health workforce capacity and that we have a workforce that doesn't adequately reflect the community. They don't speak the same language. They don't share some of the same cultural practices. There's not sort of affinity by race and ethnicity. And so we set out with our partners at Manatt Health to really lay out a deep and comprehensive report identifying specific solutions that over the long term would enable us to diversify our behavioral health care workforce and grow the capacity of it. And that sort of report cover is pictured on the left of this slide here. However, most of the solutions summarized in that report will take years to implement. They pertain to, generating a greater number or maintaining workforce of licensed clinical providers. So we started to think about, if we look across the care continuum, which is pictured in this triangle here, and we thought about the places where there are opportunity to intervene, where people end up needing mental health supports, and where we could potentially intervene in a shorter term way with a solution that wouldn't require years of training. The idea of doing something in the community with non-clinical providers became something that really shone as, again, a promising intervention where we could potentially have impact, providing people with supports in the community that would enable them to have the skills to address their own needs and ideally mitigate some of the upstream acute services that are needed. So from that, our work on Problem Management Plus was born. And I don't want to steal my colleague Jackie Anderson's thunder in explaining the model that we implemented or are in the process of implementing, nor do I want to steal anything from Dr. Giuseppe Raviola, also known as Beppe. So I'm going to pause here. But before I pass the baton, just as a process of our own foundation continuous learning in the impact of some of the work we're doing, I want to ask that we launch a quick poll. and we're going to try and do this, and ask you if you can just tell us what your familiarity is with the Problem Management Plus intervention. I see lots of you chiming in here. 1 is very unfamiliar, 5 is very familiar. Thank you all for taking the time to complete this. We are also going to ask you this at the end of the webinar. I see a few more responses trickling in, so I'm going to give this a couple more seconds. It looks like our responses are slowing. Okay, I think we are stagnant. So Jesse, you can end poll. It looks like a significant number are very unfamiliar. Thank you for taking the time to do this again. And this is part of our own foundation, internal continuous learning. And with that, I'd like to gratefully pass the baton to my colleague, Dr. Giuseppe Raviola, also known as Beppe. And so with that, Beppe, I pass it over to you. Thank you.
Thank you, Caitlin, and thank you all for being here. And thank you to the Blue Cross Blue Shield of Massachusetts Foundation for bringing us together. I'm a board certified adult, child, and adolescent psychiatrist. I practice in the Commonwealth of Massachusetts. During the COVID-19 response, I led the mental health component of the Massachusetts Community Contact Tracing Collaborative. I work at Massachusetts General Hospital, and I direct mental health for an organization called Partners in Health. Next slide. So this is a photo from the outskirts of Lima, Peru, the capital of Peru in Latin America. And these are community health workers walking to households to deliver care and support. Since the 1980s, Partners in Health has mobilized community health workers in the care of infectious diseases such as tuberculosis and HIV, and then over the past decade, increasingly in the care of mental health conditions. And it's frontline non-specialist providers, including community health workers such as these, and other healthcare staff, such as nurses, who we've trained to deliver Problem Management Plus over the past 7 or so years. Problem Management Plus is a low-intensity psychological intervention for more common mental health conditions, such as depression, anxiety, and stress-related conditions, as well as practical problems. And there's a strong evidence base for Problem Management Plus. I'm going to call it PM Plus. There's a strong evidence base that's been established in randomized controlled trials that have been published in journals such as The Lancet over the past 15 years in community settings in Kenya, Nepal, Pakistan, and elsewhere. And then PM Plus was adapted from the research and further developed and made available by the World Health Organization. And so given the needs that have been described by Caitlin before me, it can be usefully delivered by non-specialists to address common mental health conditions in people affected by adversity. Next slide. Partners in Health is an international healthcare delivery organization. We have 20,000 employees working across 10 countries and 105 government-run hospital facilities. We work to strengthen healthcare delivery systems at hospital level, primary care level, and at community levels. And chronologically, we've worked over many years in Haiti, Peru, the US, including Boston and Navajo Nation, Russia, Rwanda, Mexico, Malawi, Lesotho, Kazakhstan, and Sierra Leone and Liberia. We also opened a University of Global Health Equity in Rwanda a number of years ago. And we're involved in building community-based care systems led by community members, as well as specialist training programs. And as the evidence has emerged around the efficacy of Problem Management Plus across a range of settings, over the past more than 5 years, we contextually adapted PM Plus for implementation in community settings in specifically the countries of Rwanda, Peru, Mexico, and Malawi. And then in 2018, we started a discussion and collaboration with the Family Van in Boston, here on our call today, to integrate and adapt PM Plus to eventually create what the Family Van developed as the Healthy Roads program, which we will describe in a little bit. Next slide, please. The use of strategies such as Problem Management Plus reflects the need for us to integrate clinical and public health approaches. And this is embodied in taking into consideration a dimensional approach to mental health care delivery. We need to think about what's ideal integration of what we might call categorical approaches or diagnostic approaches that emphasize clinical diagnosis and treatment. And here in the US, our health systems are largely predicated upon categorical diagnostic or clinical approaches. And then dimensional approaches, which emphasize prevention, promotion, and recovery as part of a continuum from well-being to distress. You can see here on this blue bar from left to right, to the development of a disorder to longer-term disability. And so this dimensional approach that integrates the concept of well-being, which is the subjective evaluation of life satisfaction. It integrates the non-clinical and the clinical beyond treatment and care to include public health approaches such as promotion and prevention and support for rehabilitation and recovery. And during challenging times and crises, people move from left to right on this wellness spectrum. So part of what we're trying to do is take a preventive approach. And taken together, these perspectives invite mental health clinicians to work as part of teams at multiple levels, engaging in broader scale efforts to increase the use of these community-based approaches, as Caitlin outlined, and to support recovery. Next slide. The World Health Organization has encouraged a range of services: general hospital services, clinical care and support, psychosocial rehabilitation, residential services, to extend care and support to people's homes and to public spaces. And this expansion of psychosocial interventions and supports will be a critical evolution for the systems of the future. And so what are these? Psychosocial approaches are a range of non-pharmacologic interventions that engage adults, children, adolescents, and family members in the process of adaptive change. And this should take precedence over a medical or pharmacologic approach. And so this PM Plus approach that we're discussing today reflects that broader movement. There are many different psychosocial approaches that we could draw from, and PM Plus is one specific intervention that we've tried that represents this expansion of the care curriculum into the dimensional space of wellness. Next slide. Why use psychosocial interventions? They're the first line. They're the most effective treatments for many mental health conditions, whether post-traumatic stress disorder, care for autism or anxiety disorders or other common conditions. When there's a choice of treatment, for example, for depression, psychological and psychosocial treatments have better long-term outcomes and lower relapse rates. They enhance the effectiveness of medical treatments and pharmacotherapies, for example, for psychotic disorders and addictions, as well as common mental disorders. The next slide. You can find the Problem Management Plus curriculum on the WHO website if you do a search of PM Plus WHO, and you can take a look at this curriculum. This is the curriculum that we worked off of, both in global settings as well as in the US context. And next slide. There's 5 core components to PM Plus. The first is managing anxiety and stress, or stress management through deep breathing and relaxation. The next approach and component is managing problems or problem solving. The third approach is to get going, keep doing, which is another way of describing a method of support called behavioral activation. And then strengthening social supports as well as relapse prevention. I guess I said 5, but I'm talking about 4 across 5 sessions. So there's 4 core strategies. And PM Plus is intended to be 5 sessions. These can be modified and adapted to meet the needs of specific cultures, contexts, and individual experiences, which is really important before implementing. And so, for example, staff at community-based organizations are trained to become PM Plus helpers. Those PM Plus helpers then receive close supervision on several low-risk cases in preparation for providing PM Plus to participants. Weekly supervision continues throughout the course of PM Plus delivery, and then PM Plus helpers deliver the 5-session program, which contains these 4 core strategies or components, to the participants, to clients who are experiencing distress. And then there's various ways to think about assessing the effectiveness and quality as well, and tracking participant progress. And I'm now going to hand it off. Thank you so much.
Thank you very much, Dr. Raviola. It's really helpful for you to kind of lay out for folks to give us an understanding of the key elements of PM Plus intervention and the way that Partners in Health has been using it in their work throughout other countries and in the United States as well. Given Dr. Raviola's and Caitlin's overview of PM Plus and the importance of behavioral health, I wanted to briefly provide an overview of the Blue Cross Blue Shield of Massachusetts Foundation Advancing Community-Driven Mental Health Program, which Caitlin earlier referenced. The foundation launched this program in December of 2022, and the goals of the program are twofold: improve access to community-based mental health services for individuals experiencing mild to moderate distress and practical problems of daily living, and you heard Dr. Beppe talk about that, and for us also developing the skills of non-specialist workforce to support community members addressing these issues. This is a 3-year grant program running from December 2022 to December 2025. The first year focused on planning, and the next 2 years will focus on implementing PM Plus at the funded organizations. The 5 grant partners you see on the screen: Boston Senior Home Care, Cambridge Economic Opportunity Committee, Asian Quincy Resources, Stavros Center for Independent Living, and the Community Builders. These organizations address a range of issues for their clients, whether it be housing, support for people with disabilities, senior housing, and other community-based direct social services support. In addition to those 5 grant partners, this program has 3 other partners to support the foundation in this effort. Partners in Health, and you heard from them a little bit already, and you'll hear after this, the Family Van, who both provide expertise, coaching, training, curriculum development to help grant partners successfully adopt and implement the PM Plus intervention. And we also have a third partner, the Institute for Community Health, who's responsible for the evaluation of this program. We're in the final stages of the planning year that have been focused. This planning year has been focused on training staff and preparing organizations to implement the PM Plus intervention. Over the last 10 months, grant partners have assessed their capacities and the areas that they will need additional support to implement PM Plus in their organization, adopted the customized World Health Organization participant manual that you saw that Beppe showed you on the slide. So that, as you mentioned, that can be adapted for different organizational contexts and community contexts. They've also participated in monthly learning collaboratives with fellow grant partners and technical assistance and coaching calls as they move to get their organizations ready to implement the program. And finally, in September, they attended the in-person and virtual training on the core elements of the PM Plus intervention with funded grant partners. And right now, they are beginning to enroll their first clients in the program. So during year 2, so we're just at the tail end of year 1, in year 2, the trained staff members will provide the PM Plus intervention to their clients. They will participate in ongoing training. They will have regular supervision sessions with their clinical supervisor, because that's a key element of this program. They will continue their learning communities, and they will be provided technical assistance and coaching from Partners in Health, the Family Van, and Institute for Community Health. I want to show a last slide, and the last slide before we turn it over to the Family Van shows the core PM Plus core skills training that happened, that the organizations participated in September. What you see on the screen is an example of 2 of the trainers modeling the intervention as a part of their training session. You know, the beauty of the PM Plus intervention is that it's not a one-size-fits-all intervention. So what you'll hear from the next speakers is how they each worked and adapted the intervention for their own organizations and community contexts. You know, as we test and adapt the intervention while keeping fidelity with the PM Plus intervention, grant partners can implement the program in a way that works best for their organization and their community. And we anticipate that they will refine it the more experience they gain in implementing the program. So that's just we have just the starting point of this, of our work here. But I'm turning it over now to our colleagues at the Family Van, Piper Derencourt and Renelle Walker-White? Renelle, I've forgotten your name. Renelle Walker-White, and who will talk about their work on the PM Plus intervention. Let me turn it over to Renelle and Piper.
Good afternoon, everyone. My name is Renelle Walker-White, and I am a community health worker, and I also am the Associate Director of the Family Van Health Equity Program. And today, my colleague and I will talk a little bit about the Family Van and how we started working in the community and how we work alongside of our partners and how we engage our community members to living healthier and living longer lives. Next slide, please. Who are we? The Family Van has been founded back in 1992 by a Dr. Nancy Orio, where she felt that the community really needed to have this program in depth and engaged in the community. It's an opportunity for us to really work alongside of our community members, where it was community driven, it was community led, where we went out and we asked the community if this is something that they needed. The community was very, very happy to know that there was somebody in the agency that really cared about their needs. So it's community driven. It's an opportunity for us to get out into the community and find out what they are in need of. It's led by culturally diverse, multilingual community health workers, trained and educated, coming from the community, knowledgeable in the work that they do, trusted by everybody that they see, and they know that there's lots of resources. It's an opportunity for our community health workers to really know the people that they work alongside of. And as we promote these equitable programs and this care, we are out in the community and we're serving Roxbury, Dorchester, and East Boston. There are communities that really need our work. We wish that we can expand the care, but at this moment, we're able to just take care of those communities. And these communities really are communities that are underserved, and they really need the help. Next slide, please. How are we addressing emotional health on the Family Van? When you think about it, back in 2016, we needed to know that a lot of people were coming on talking about fear. They were talking about anxiety. They were talking about depression. They were talking about family problems, talking about community violence. And it was an opportunity for the Family Van to hear what these people were talking about. As we engaged in the community, as we listened to them, we felt like we needed to have some listening sessions. So the Family Van came together with community organizations, people from the community and all of the different sites that we visited. And we just sat down and had a conversation, had a candid conversation. What's going on? How might we be able to help you address some of the needs that you're going through? We know families are really struggling. We knew that parents were struggling with their children that were going through mental conditions and disorders. How do we as a community listen? What do we do? How do we get back this information to the people that really need to hear this information so that we are better able to make a concise levels of healthcare so that they're able to adapt to the different changes that they're going through in life. We partnered up with, we found PM Plus, which is a research entity that really the model was really the model that we needed. It was a PM Plus was a model where we can work along getting engaged with 5 sessions and trained on how to get the skills that we need. How do we get our community engaged in the work that's going to allow them to get from point A to point B, just one step at a time. We were trained, we were educated, we learned how to adapt these sessions and these tools to our community. But how are we going to get it out to the community if we don't have the funding? We were able to secure this funding back in 2019, which was an opportunity for us to really get out there and get this work in the community and take care of the people that really were at need. The initial PM Plus adaptation and the training started back in 2020. It was around COVID time. So we did all of our training virtual. It was an opportunity for us really to sit down and to just listen to PIH and to Blue Cross Blue Shield and to understand what ways can we really get our community to live longer and to help them to get into places where we know that some of the physicians, the psychiatrists are not able to meet those needs. So as we got trained, it was an opportunity for us to really engage and to launch our program. We launched back in 2021, where it was an opportunity for us to really get out there, listen to the client, do some health screenings, find out what they needed, and to address those needs. It's an opportunity for us as community health workers who know the work, who know the community, who are trusted, to really get out there and make a difference in somebody's life. Can I have the next slide, please? As we're looking at key adaptations and strategies, it's really relational screenings. You need to really understand, how do you screen people? What are the questions that you need to ask to really get to understand what's going on in somebody's life? If you don't understand what's going on in their life, you're not able to serve them. And we want to be able to serve them wholly. We're flexible. Family Van is flexible. The Family Van is a mobile unit. We go to the client. We are meeting the client where they are at. Most people in institutions, they're working in agencies, and the client has to go to them. We're going to our communities. We're taking care of the total person. When you think of the whole person, you're thinking of from head to toe. Every part of the body is important. And as a community health worker, we engage each and every part of the body. We're talking to people, we're seeing people, we're listening to people, we're understanding where people are coming from. It's strengths-based. It's all strength-based. We have to understand that we need to work together. We need to be able to partner with people. We're not able to do this work alone. As I said before, the physicians, the psychiatrists, they're overwhelmed. Their workload is high. So what do? We have to really get these trainings in so that we can show that we can redefine our successes. When you think about it, how do you redefine the success? How do you know that you're making a difference in somebody's life? The way that we do the work that we do, people are coming to us each and every week. We're making appointments with them. Some sessions, we can do 5 sessions with some people, but at the same time, 2 or 3 sessions are going to make a difference. How do you measure success? You measure success by the way that somebody is doing something different. They're able to engage a little better. They're feeling a lot better about their life. They're moving more freely, and they're talking and getting out. A lot of times people are not able to do that. But with the time that the Family Van is adapting and doing the work that we do, we're able to just see the person for who they are. We're culturally responsive. When you think about it, the community health workers are coming from the community. They work, they live, they pray, they eat in the community. They know the languages. They're coming from some of the native countries and islands that a lot of the clients that we see are coming from. Who better to take care of the community than the people that are engaged in that community? They know the culture. They know how to take care of the people. That's how they're trusted. That's how we adapt the work that we do. And it's community engaged. We want to make sure that the work that we do is community engaged. We cannot do this work alone. We have to continue to work alongside of our partners. We have to continue to educate people to the best of our ability to make sure that they're making a difference in somebody else's life. Staying in the community and engaging in the work that we do is really the key. It's really the key. And I'm going to turn this over to Piper.
Thank you, Raynell. And thank you for giving a wonderful overview of some of the tremendous lessons we've learned over the past 3 years. We launched our pilot in January 2021, thanks to the Blue Cross Blue Shield Foundation, and then through some additional funding that we received over the years. And while we have seen so much impact from integrating PM Plus into our service delivery model, we've really seen the benefits of being able to now have a truly head-to-toe approach to health. So many of our clients are struggling with chronic health conditions, at least one, and then a variety of social stressors from housing instability, food insecurity, increased violence. There's just so many different drivers of distress. And the numbers that you see here today are based on a small but very mighty direct service team that is involved in screening, referrals, and we have currently 2 lead community health workers, including Raynell, who conduct sessions on a part-time basis. And through our work thus far over the past couple of years, we've seen that a team-based approach has really been able to help us identify who can benefit from PM Plus, who's ready for PM Plus, and who might need something more specialized. And through our long-term partnerships and community-based organizations that we have been working side by side, we've been able to bridge clients to that additional support when they need it. And so many of you might be wondering, so do clients feel better? It's a pretty brief intervention. And the answer is yes, the vast majority do. While we hope all of our clients would be able to complete all 5 sessions like Raynell mentioned, we have found that clients who attend at least 3 sessions see a reduction, a 40% reduction of mental health distress. We have also seen the benefits within our initial screening conversations that happen on the van. We've seen a reduction in stigma, that clients feel more open and willing to talk about the different stressors that they're facing, and that many clients may not be ready to engage in a formal program, but the fact that they feel seen, they feel heard, they feel cared about in a culturally responsive, non-stigmatizing environment can create a sense of relief, empowerment, and a sense of a safety net. If there's something wrong, they know where to go. And overall, PM Plus participants not only feel better, but they walk away with free, valuable skills, tools, insights, and referrals to navigate future stressors. And another key question some of you may be wondering is, does this increase workforce capacity? And the answer is yes, it does. And it highlights a critical need to diversify our workforce and be more expansive in how we define mental health professionals and how mental health can be offered. For example, we've witnessed the exponential value and expertise our community health workers bring to this work through rapport building, lived experience, a deep understanding, and commitment of community strengths and barriers, as well as community partnership. We need more non-specialists at the table. And one important reflection we've had at the Family Van is not only how do we expand our workforce, but how do we retain staff in this type of work? It's hard work. It takes time. You need resources. And for us, this has been directly connected to our organizational culture. While many workspaces are transactional in nature, we intentionally cultivate relational spaces where staff are valued, have growth opportunities, and are structurally supported and directly involved in decision-making. So that's to say, like, if you're thinking about PM Plus, it's not an intervention that's necessarily going to be the cheapest intervention. It is something that is cost effective, but you also do need to invest in staff and staff wellness and the structures that will help people thrive in the workplace to support others. Because if staff are not well, they're not going to be able to sustain this type of work. Next slide, please. And Raynell, I'm going to pass it back to Raynell to talk a little bit about the impact that she's experienced herself as a provider and in the communities that we serve.
Thank you, Piper. As you all can see on the screen, the impact that Healthy Roads is an entry point to mental health support. My needs were understood and acknowledged. And using a holistic view of me as a person, I was given coping tools and strategies that worked for me. In my experience, the clients that I have worked alongside, and I want to say walked alongside of, have really had a great impact as far as knowing that their needs were met. They were listened to, they were saw. A lot of times people don't feel heard, people are not seeing them, but the impact is that their lives have changed, they're thriving, they have transitioned, and they're living well. They come back, and I still have clients that are calling me months after I have discharged them out of the program, just to say thank you. I'm moving forward. I want my friends to be involved in this program. It's an opportunity for somebody else to walk alongside of them because we walked alongside them. Our community health workers have really made a difference in the lives that our clients have, our clients have really truly just made a difference in our lives as well. It's, we're not an island on our own. And we just know that the work that we do is not going unnoticed, and it's making a difference in many people's lives. And I'm just here to testify that, the work that PM Plus is doing, Healthy Roads is doing, Family Van, making a difference. And I wish that everybody would be able to take this program and just make it your own, make it uniquely your own, so that you can diversify your workforce, and that the community health workers will be able to do the work that they so desire to do. Thank you so much.
Thank you very much, Piper and Ronell, for providing, an overview and really talking about the impact of your work in the lives of your clients. And I think also the fact that you talk about the importance of self-care, and that the importance of supporting the community workers on the Family Van in implementing the PM Plus intervention. And now I want to turn over to Dr. Adam Brown. And Dr. Adam Brown is from the New School out of New York, and he will talk about the work occurring in New York through Recoup New York with PM Plus intervention. Dr. Brown, it's yours.
Thank you so much, Jackie. And a huge thanks to everyone who organized this, and for all the speakers who had come before me. It's incredibly inspiring to see it all together. My name is Adam Brown. I'm a clinical psychologist and an associate professor at the New School in New York City. And I'll just give a little bit of background leading up to the work that we're now doing throughout New York, but in other cities across the US as well. So back in 2019, my lab and I were thinking a lot about many of these issues already. How do we increase access to care for individuals in places like New York, outside of New York, where people have really been on the outskirts of many systems, and due to many barriers, stigma, complex administrative challenges, lack of trust in certain healthcare systems, folks were not getting the care that they needed when they needed it most. So we were in touch with the World Health Organization and other UN agencies to begin discussing ways that we could adapt Problem Management Plus from the work that Pepe was talking about in other countries, and thinking about bringing it to places like New York City. And we had started doing that work in 2019. And then, of course, COVID-19 hit in early 2020. And at that point, not only did we realize in such an acute way how important these kinds of strategies are, but we had to think relatively quickly about ways that we could deliver both the training in Problem Management Plus and the delivery of the sessions remotely. And so I did see there was a question that came in before about training, and I can speak to that a little bit. So Problem Management Plus training is approximately 60 hours that you do. Traditionally, when I was first learning how to do Problem Management Plus, it was usually around about a week and a half, almost 2 weeks, with lots of people in a room together, where you would, do the whole training at once, and you do lots of role plays and you learn how to deliver it. Of course, in the context of COVID-19, this proved to be not safe. This was pre-vaccines, still learning a lot about the virus, but also knew that we had to figure out a way to build capacity in places like New York and elsewhere to make sure that we could deliver these kinds of important psychosocial services. So as a team, we began working with the Red Cross, with WHO, and with other folks to adapt the training to be remote. And we did it over Zoom, but we also used a number of other digital platforms at the same time to make it feel as immersive as possible. We wanted to make sure that all the role plays, all the interactions that really help people to learn the skills were there through the digital training, in the same way as if people were in person. And to date, I would say 99% of the trainings that we do out of the New School are remote, whether they're in New York City or in other cities and other countries that we're partnering with. Because this was, to our knowledge, the first attempt to bring Problem Management Plus to the US, we did a couple of things. One, we really spent, it was rapid, but we did spend some time working with the communities that we were going to partner with to make sure that the materials in the manual and in the training were culturally and contextually responsive. So as was mentioned before, you can go to the WHO website and download the manual for free, and you can take a look at the training manual and all of the strategies that's available. But you can see that it comes with certain illustrations and language that may not always feel so relevant to the local communities and contexts in which you're working. So we didn't have a lot of time, but we rapidly tried to adapt this to make this look and feel a little bit more contextually relevant for the context and the challenges that New Yorkers were experiencing at the time. The other thing we did was, because this was, to our knowledge, the first time that PM Plus was being delivered in the US or a place like New York, is we wanted to do this in a very careful way. So outside of the US, this has been done for a number of years already, demonstrating that community health workers, other non-specialists could deliver this effectively. But since we were doing the training online during a moment of COVID, we thought the first step would be to train psychology students at the master's level or at the beginning of their PhD as the first group that we trained to assess if we can do this. One side note really quickly is that there is a tool developed by the World Health Organization called ENACT, E-N-A-C-T. And what that is that's a competency-based tool where you can assess the individual getting trained in PM Plus before and after, to demonstrate that they are learning the skills that you hope that they have before they begin doing this work, which of course is a really important piece, I believe, in this workforce development idea, that we can ensure that over the course of a brief training, people are really acquiring these important skills. Then once we trained New School students who are psychology students, we also began partnering with a number of community-based organizations in New York City to also remotely train them as well. And what I'd like to show you quickly right now are some of the outcomes of that data. So this was a single, if we can just go back one slide. This is the result of a single arm trial. TNS stands for the New School. So these were 20, this was PM Plus remotely delivered by New School students, graduate students, to 26 individuals in the community. And then we had individuals from community-based organizations who delivered it out to 18 individuals. You can see that the demographics of those who received the intervention differed considerably, whether it was delivered by New School students or people in the community. So for the New School students who delivered it, there was some diversity, but it was predominantly white. For the folks from community-based organizations, they delivered it. The population was predominantly Black or African American. On a lot of the other variables, it was fairly comparable. If we can go to the next slide. Consistent with the data that we just saw from the family van, the news is, this is, at least in the short term, fairly effective. Remember, this data comes from during COVID, all being delivered remotely at a time when people were feeling a lot of stress and quite a bit of uncertainty. And nevertheless, the Cyclops is a single item of distress that people are experiencing. We saw a significant decline there from baseline after. The PHQ is a measure of depression, significant reduction. And the GAD-7 is a self-report measure of generalized anxiety disorder. And you can see across all three of these constructs, a significant reduction in distress. If we go to the next slide, just to show you a little bit more data, we can see with a little bit more clarity, the kind of change from baseline to post-assessment. And we didn't see any differences between the new school students and the folks from the CBOs, suggesting that, you know, having some background in clinical work is not necessarily needed to show strong benefits in Problem Management Plus. In the last graph on the bottom right that you can take a look at is the WHO-QoL, which is a measure of quality of life. And I think this is really important. Not only are we reducing distress, but we're also able to show in the short term, you know, we need more long-term data, but in the short term, people are also reporting higher quality of life. If we can go to the next slide. So this single arm trial, you know, we can demonstrate we can train people effectively in the community. We can show in the short term that we can reduce a variety of forms of distress. We were fortunate to receive a grant from the National Institute of Health, which is a 5-year randomized controlled trial that we called RECOUP, Restoring Mental Health After COVID-19 in New York City, in which we are now carrying out a much larger study with roughly 1,600 individuals to really be able to test these ideas on a larger scale around safety, acceptability, the efficacy, and the return on investment, the affordability of these kinds of strategies. And this is underway now. The training and the implementation of PM Plus is happening across nonprofit organizations in New York City in partnership with the Mayor's Office and George Washington University. If we can go to the next slide. As I wrap up, I just want to highlight again, it was mentioned before so eloquently that you can make PM Plus your own. You really do need to stick to the strategies that the evidence was built around, but you can do a lot of adaptation. We learned some things, especially coming out of Nepal, that we now use in New York City, this idea of using workbooks and other strategies to help people reinforce the kinds of things that they're learning between sessions. And all of this was done in partnership with the communities that we work with. And if you can go to the next slide. And just a huge thanks to everyone. And, you know, while we are rolling this out in New York City, it is so exciting to hear about the synergies happening in Massachusetts. We recently did a training of trainers in Iowa for the Bureau of Refugee Services, and we recently just launched a new program called HopeX in Duluth, Minnesota, where we're also going to be training, adapting, and implementing PM Plus in that community as well. So just want to say a huge thanks to everyone, and it's so exciting to see this work growing and evolving in really exciting ways. Thank you so much.
Thank you very much, Adam. It's great to hear the work happening in New York. And, you know, what is interesting is that we actually found Adam from doing the brief, the PM Plus brief that Caitlin spoke about earlier. And in doing our research, we found that Adam in New York was doing this model. And so then we heard about Jerome, who will be up next as well. And so we wanted to make sure that we highlight the real flexibility of this model. And it's been used with so many different, with community-based organization, community health workers, social work students. The gamut is wide, as long as you stick with those 5 principal or 5 core elements or 4 core elements that Beppe spoke about in the beginning of the presentation. And as I turn it over to Jerome Galea, I want to remind folks, if they have any questions, please feel free to write your questions in the chat, in the question and answer bar at the bottom of Zoom. And after Jerome finishes, we'll open it up for questions and answers. So let me turn it over to Jerome.
Great, thanks, Jackie. Hi, everybody. I'm Jerome Galea, Associate Professor of Social Work and another licensed clinical social worker. And as Jackie was saying, I'd like to share with you a slightly different perspective of PM Plus, and that's the perspective from the student learners. So I won't be providing recipient data here, but really looking at what it was like to use this in an educational setting amongst social work trainees, first-year social work students. And I just want to also echo what was said by Adam before me. I'm surprised we haven't met, but I have thought of, I've been so engrossed in PM Plus really outside of the US. And it's been really gratifying to hear about it expanding within the US. Global mental health includes the US. And so it's great to hear about your work. Next slide, please. So a little bit about how I got involved with PM Plus is, well, you can see a picture at the bottom right is Bepi is there. I was working with Partners in Health and living in Lima, Peru for about 15 years, where I learned about global mental health actually through Bepi. I was definitely recruited to the cause and trained and did my postdoc with him before coming to USF. And part of that included implementing PM Plus in Peru in 2018. And as has been said before, as long as you maintain the core ingredients, think of PM Plus kind of like bread. You need the flour and the yeast, or you're not going to have the bread, but you can add to it, you can make it, you can adapt it. And that's exactly what we did by creating EP Más, Enfrentando Problemas Plus in Peru. That just means problem management plus in Spanish. When I moved to Tampa, Florida to work here at the School of Social Work, I began volunteering with a student-run clinic here called the Bridge Clinic. And Bridge Clinic provides free care to uninsured individuals in our community. It's been around since 2007, and it includes medicine, physical therapy, social work, pharmacy, and other specialties. And I noticed volunteering there that the patient populations we were working with here at the Bridge Clinic were in some ways very similar to the populations in Peru. So in our population here, it was mostly Spanish speaking. About 70% of the patients were Spanish speaking. That was the biggest similarity. Many here did not have access to health insurance. None of them had access to health insurance. That's why they were coming to our clinic. Many without documents, many economic migrants, agricultural workers, the 200% below the poverty line. And previous studies had found depression symptoms very common in this population. So when I became involved in the Bridge Clinic here, one thing I noticed is that I felt like the social work practice was really, the scope of practice was constrained. And it was really limited to resource navigation, which all social workers need to know and do, but we can do a lot more than that, even at the trainee level. And so I thought to myself, well, if we're teaching, community workers with no mental health experience in Peru to deploy PM Plus, why not teach the MSW student volunteers PM Plus? They could add that to their tool bag. And so we decided to do a very small pilot of just the feasibility of training and implementing PM Plus among a small group of social work students. Okay, next slide, please. Thank you. So, again, these MSW students were already Bridge volunteers, and they saw the needs of the patient population, and they were taking coursework as part of a social work student. All of the MSW students were bilingual. So we decided to really focus on Spanish-speaking patients. So the training, there are different reports of how different people conduct the training. What I can say is that when we did it in Peru, it was a 40-hour training. We sat around a conference room table and we went through it from zero, all the way to the end of the day. But really, what we found with the MSW students is that it was clear they had basic skills because they were already receiving counseling. We're a clinical program here. And so what they mostly needed was to practice the recipe of PM Plus. So they were primed to deliver psychological support, hungry for the experience, and could benefit from learning a protocolized intervention. So our training plan came down to 3 4-hour in-person sessions, Canvas coursework. I'll show you what I mean about that in a second. In-person and video role plays, and pre and post patient accompaniment by a licensed social worker. Okay, next slide, please. So here I just want to show you, these are kind of small pictures. But on the top left, you see Canvas. Canvas is what many universities use for our courses to give out, to conduct, whether the course is online or in person. Canvas is a place where we put the syllabi, we put our modules, learning tools, quizzes. Below that, on the bottom left, you can see I had little quizzes. That is not typically part of some of the trainings I've done for PM Plus, but we decided to do that. These were students that are used to doing kind of learning checks. On the top right, we did skills demonstrations where students could walk through the course online and the training for PM Plus, and they would work in dyads and submit a video of a role play. And then we would give them feedback. On the bottom right is an example of giving feedback to a student. And I also included supplemental readings on depression and anxiety. You'll see our contact information later. I'd be happy to share in much more detail all of these materials, but that's how we conducted training. But then also we had some in-person training here on campus. This, by the way, was right before COVID, fall of 2019. Okay, next slide, please. One thing that my guess is was used by other presenters, I know for sure Partners in Health does this because this is really where I learned about it, was this idea of a care pathway. So the care pathway on the right really just shows you a way. The idea here is that you can identify who could benefit from PM Plus, but really PM Plus is one intervention, but there are people that whose needs, say for example, if they have active suicidal ideation, they really need to talk to a specialist. And so the idea of a care pathway is that you can triage or screen people, the majority of which will most likely receive and benefit PM Plus. And we use the patient health questionnaire, which is not a diagnostic tool, but it does a really good job of measuring the frequency and prevalence of depressive symptoms. And so in this pathway, you can see that we were providing PM Plus to folks that did not have active suicidal ideation. And if they did, then we would link them to care. So that's the basic care pathway. Okay, so let's go to the second to last slide. This is these are some really interesting student outcomes. So just from the perspective of the students said things like, this experience, so learning PM Plus, allowed me to quickly develop my confidence in my abilities as a counselor, as it provided me with structured tools and a manual to look over as a new therapist. So interestingly, in social work, we don't actually teach people manualized interventions. We teach them different strategies, and then they can go on and learn interventions they can take as an elective, cognitive behavioral therapy. But what this person was really saying is, like, I can start out and go into my internship and have something. It's low intensity, but it's something. Another said, I was able to utilize PM Plus in my personal life and even take on components I learned and apply it with my clients in my internship. And then the final person said, PM Plus also provides several skills that can be applied to other therapeutic modalities. I think learning about PM Plus as an MSW student provides a foundation that increases students' confidence in working with clients. For instance, goal setting is part of any treatment plan. And so what I want to just point out here is that even amongst people that are learning PM Plus, they can apply it to their own lives. And so it offers new opportunities where this intervention could be used. So again, I just want to say this was small. We only had 5 students. We were with them in the clinic as they did this, but our future directions would be thinking about maybe building this out into a course with many other different low intensity interventions. Offering it in English would be another future direction. Of course, we'd like to do things like tracking patient outcomes as well. And I'll just wrap up in the last slide here, saying if you'd like to read the full story, we have it published in the Community Mental Health Journal. I just want to thank the students of the Bridge Clinic, the social work students, my collaborators, Melissa Thompson and Chris Simpson. Thank you, everybody.
Thank you very much, Jerome. We appreciate it. And now it's time for your questions. And I know we've seen some questions come in. And as we're doing that, I'd like to ask the panelists to come back on the screen so that we can have everybody there. And here we go. Wait a second for, there's Adam and for Beppe and no, great show. Thank you. I guess the first question we have here is one that I'd love to hear all of you kind of speak to, whoever would be interested. And the question really is, while I know you're all experiencing some barriers and challenges, you're all here today because you've seen some success in the programs you've established. If you had to identify one non-financial factor that contributed to the successful implementation of your program, what would that be? So one non-financial factor that contributed to the success of the program. So let you think of that for a second. I'm going to start. Oh, Beppe?
There was a question in the chat about payment of community health workers, and I put a link in there from chwimpact.org because I think that paying people for their time, we have to kind of overcome this idea that mental health care is easy and we can create mental health care from ether without humans. And I think that COVID has sort of accelerated all of that. And of course, it's very exciting to think about technology and apps. But what we're talking about here is the distillation of common effective elements of psychotherapy into non-clinical psychosocial approaches delivered from one person to another. And I think that Raynell, who has so much experience in this, really captured the passion around that. But what I want to say is, we have to really think about that payment piece and the various factors, including financial, that go along with supporting non-specialists.
Okay. Adam.
Such important points, Pepe. And I guess two things I think about really quickly. One was when we first started doing training remotely, it became pretty apparent that were things that we really had to get input in from the community to figure out what would work from them. So the 2 weeks nonstop training was not going to fit into their timeline, and we had to reevaluate how training was going to happen. One of the biggest innovations for us, which I think is also happening in Massachusetts, is that as people do the training, the people getting trained are also doing a version of PM Plus themselves. And so we're finding that they're not only learning how to deliver, but they're also learning how to apply it to themselves, which Jerome was speaking to some of those benefits as well. The other big non-financial thing that we discovered was the importance of coordination across sectors. So in New York, we work very closely with the mayor's office, who has been instrumental in helping us to build those partnerships. So having a government partner on board is huge. And then really close working relationships with community organizations who obviously have, the trust and the buy-in. But those multi-sector partnerships are invaluable for people thinking about doing this work.
Thank you. Piper, Raynell, anything you want to add?
Yeah, I'm happy to add a couple of things. I think for us, there have been a couple of things, and I'm sure Raynell will add to them, but I think having funders that allowed us to really move beyond the status quo and question the status quo in terms of how we screen clients, what are the goals of the session. So we really kept to the fidelity of the skills, but how we went about it really allowed us to make sure that we could integrate that community input, because we continuously receive it, but it's important that our funders also agree that we can integrate it and understand why we're doing so. And I think alongside that is really having providers that share and live and eat and pray and sleep in the same communities that we're serving. There's that inherent trust, and we're able to reach people that aren't being historically captured by the health systems because of the distrust. So I think that we've seen a lot of progress there. And the third thing is around the organizational culture and support. I think that we were really able to invest internally in staff on organizational professional growth and opportunity, making sure that we do wellness workshops on a regular basis, that we're having moments to debrief with each other. And I think that has led us to sustain, PM Plus at our organization. Raynell, do you have anything to add?
Thank you, Piper. I agree. And thank you so much, Adam, because I think that everybody needs to do PM Plus on themselves because it's an opportunity for us to really engage in our total being as well. And so to add to what the panelists have already said, I can definitely say that staffing. I think that when you work alongside of your staff and you really know each other, you're able to kind of like, to work in a place where you're engaged and at the same time you're resourceful, you tap into the community and you get what the community can give you. And at the same time, we have to work together. And so I just see that the clinical perspective that we got, the support that we would get from Piper and the wellness classes, it just really just made our day because you're taking in so much. As a therapist, you're taking it. So as a community health worker, you definitely have to, let some of that steam off. You have to be able to be in a place where you can just live and breathe. Like as we're teaching them how to breathe and how to get past how to get past one place to get to the next place and how to keep striving and keep moving and doing what we need to do. So I think everybody needs to do PM Plus. It would benefit us all.
Thank you all. I want to turn this next question to maybe Piper. And one of the questions is, and referring it to the recent Advancing Community-Driven Mental Health Program, how do you train community members to deliver PM Plus? And what does the training process look like? Because I know even though there was a week that you trained, this has been a 9-month process. So can you talk a little bit about that? Because it's different than the community health workers or the social workers that Adam and Jerome spoke about, or even Beppe.
Yeah, I can start us off and I'm sure others will be able to complement what I say. But, I think one of the important lessons that we've learned is the community input and buy-in and making sure that there's a few months of preparation and bringing in such a new service, especially if behavioral health isn't something that you're currently offering. At the Family Van, even though we were supporting clients in this way, we didn't have it on the menu per se. Especially with the Advancing Community-Driven Mental Health and community-based settings, there is some preparation that needs to happen beforehand. And so we took about 9 months of preparation to really make sure that there were the structural supports, the resources, that they had adapted the manual to their unique setting, their unique population, and then went through about 3 weeks of training. It wasn't every day, and it was a mixed format of hybrid, and it was a hybrid format of virtual and in person. But we did take a little bit of a different approach of really making sure that the PM Plus providers were almost clients, and understanding what it felt like to go through the sessions as a provider and as a participant. And so we were able to do this through role playing and modeling of the sessions. And I know that Adam, you might use some similar tactics, but we found that to work really well. Everyone left feeling like, okay, I know where to start. I know what to do. And then there's so much more continuous learning that just happens through actually offering these sessions and having ongoing supervision and support to continue to develop skills. It's not like you walk away from the training and now know the intervention in and out. You know enough to get started, but it's the ongoing training and support that we have found very valuable.
Anybody else want to jump in on that question as well?
Just to reiterate, I know I mentioned this quickly, but we work very closely with that competency-based tool called Enact. And I think for us, this has become a really important piece of the training that we do before and then after, and then we do some supervised practice cases as well. And so for us, in thinking about, many of us go through years of, some kind of clinical mental health training before we start delivering interventions. In this case, if you have 40 hours, 60 hours, how do you ensure that people have those basic helping skills down and they feel really comfortable? There's lots of ways to assess that, but it's nice to have a role play, competency-based tool that you can evaluate people's readiness before they begin doing the work. And that's become a really important integral part of our training.
Thank you. Pepe, I have a question for you. And this person said, I was curious about the dimensional approach spectrum shown at the beginning of the webinar, and I think that was one you wrote. Does the spectrum and PM Plus approach take into account that someone can both have a persistent disorder and still maintain a sense of well-being through treatment?
Yeah, that's a beautiful question. I think that what we're trying to do is blend both approaches. And as has been described, for example, in using PM Plus, we use the PHQ-9, right? I mean, the PHQ-9 in our context in the US, it's sort of we think of it as a clinical measure where we stratify the mild, moderate, severe depression. And a lot has been written about the collaborative stepped care approach within primary care settings. What we're trying to do here is move out of the clinical lens, away from the clinical lens, but that doesn't mean we can't use the same tools to identify people in distress. So we might use the PHQ-9 and find that tool really helpful because you get a score and you can get some sense of the severity of the problems from that perspective using that tool. You can also show progress. We can marry both approaches, but I think philosophically, in terms of how we think about mental health and behavioral health in the US, the categorical diagnostic approach is how we reimburse. And so that also is something for us to think about. How do we move to, for example, reimburse essential elements of care that might not be biomedical? And so what we're saying here is that those 4 core skills contained within PM Plus, they're non-clinical, they're psychosocial. Did I answer your question? I think that we can hold on to both spaces.
Thank you. And you mentioned an important thing of how do we continue to support this work? And I'm going to ask you guys a question. I'm going to do a final poll, but I want to ask you a question to think about while we do the poll. And the question is, absent philanthropy, what is your thinking about what strategies we can use to replicate, scale, and sustain this intervention? So think about that. I'm going to ask Jessie if she could start the poll, and then we will come back to you, and we'll start with Jerome on this question. So I've teed you up already.
I was answering.
You have a minute, Jerome. You have a minute. So you have a minute.
Hold on. I was answering a question in the chat. Well, I heard philanthropy, but I didn't hear the rest of the question. Could you repeat?
Absent philanthropy, what is your thinking on what strategies we can use to replicate, scale, or sustain this intervention? So if nobody's funding you, so what's your thinking?
So I'll say it. Actually, I kind of answered this question in my talk. Where I'm thinking from my perspective, working in a school of social work, is I think all social workers at the bachelor's level and master's level should learn this, and other similar interventions that I call, they're called protocolized, things they can take. They should learn them in the classroom. They will help them in their lives as students, as we've seen, but it will also help equip them to as they go on into training in their clinical work. So I would say we just have to make it structural. It has to be part of an educational policy. I think I teed that up for somebody else.
Thank you. Who would like to jump in? What should we be doing to sustain this model given absent philanthropy?
I'll just say that in our work in mental health at Partners in Health, we started absent philanthropy. And so how do you create philanthropy? And from our experience, one thing we did was start small. Another thing we did was actually deliver care. And the third thing we did was collect some data that's useful, kind of like what's been described today, that the data is really critical. And maybe fourth, really engaging clients and families in the process. And in fact, you know, a lot of research that we've had done has been sort of qualitative assessments of the person's experience of care, which also can be hugely helpful. And those things taken together can often help to build that interest in philanthropy.
Adam, I know you have
Yeah, I
been
would say that we can continue
Okay.
to have.
Oh, sorry. Go ahead, Renelle.
Yep.
Renelle, you're on.
Oh, I'm sorry. Yes, I think that we can continue to have conversations in the community. The listening sessions will definitely help. I think that people really need to get the word out, and the more that the physicians and the people that are doing the services that are licensed know about this type of work, I think they're able to really help to leverage and to get the word out to other people so that we can get this information to the community so that we can train people that are not licensed.
Mhm. So training people that are not licensed, thank you, and really thinking about, okay, if we train people that are not licensed, where's the money coming from? Adam, where's the money coming from?
So I think the money is going to come from policymakers, government officials who are going to recognize the return on investment through these strategies. And one of the things that we're really starting to explore both in Minnesota and in New York are strategies for accreditation and certification for folks who, in addition to social workers, which I think is a brilliant idea, you know, also thinking about community health workers, peers, other individuals in communities who can be trained in these low intensity interventions, but who can earn a livelihood doing it. There's so much evidence around these strategies like PM Plus and other strategies. But what we see, and again globally, is that once the grant money goes away, it's very, very hard to sustain. And so we really do need some shifts in policies where we see this as part of a continuum of care. And I think one that could actually show significant return on investment.
Thank you, Adam. You know, I know we're almost running out of time, but I just kind of wanted to leave it with our panelists. Any final thoughts you have for our audience regarding the PM Plus intervention? What's one thing you would say to the folks that are interested, that are participating in this webinar today? Any final thoughts that you would have?
Well, I could say that it is a program that is worth you looking into and having your staff trained on, because it's an opportunity to train the trainer and to be able to communicate and to work into the community so that one person will lead to another person, a domino effect. And when you look at it as a domino effect, the community becomes well, people heard, and action is taken. So let's take some action and try to get this information out so that people can learn about it and be trained.
Thank you very much, Renelle. Any final thoughts from Beppe?
You know, we talk about evidence-based practice, and this is an evidence-based practice because there's good evidence for it, but also we talk about practice-based evidence. And I'll just say that going back to the beginning of this process, we actually at Partners in Health, we've tried various things. We have been agnostic about the actual intervention. And what we've learned, embodied in a paper I shared in the chat, is there's something about Problem Management Plus that's very appealing because of the way that it nests different components of interventions together. But there's not too many sessions, there's not too few, and it seems to really hit a kind of sweet spot that seems universally across where we've worked to be very appealing both to the providers and helpful to the people receiving care.
Thank you. Well, if nobody else has any final thoughts, oh, Piper has a final thought.
Final thought of like what we've really seen is that it can really reduce those barriers and increase access to equitable care. So depending on who's being trained, we can really diversify the mental health care workforce, which we know can increase access when we're bringing it directly to people in the communities where they live. So I love the idea of, training BSW, bachelor's level social workers, because we know that many people face barriers to getting higher education, but also community health workers and other maybe the peer specialists, but thinking about who's already connected at the community level that is representative of the communities that most need this care. So I think, the intervention itself, again, really does reduce those barriers. And I would hope that we can expand it together and, have a cohort of people who are learning together.
Thank you so much. As you see, the slides, you will be getting them afterwards, and the contact information for each of our panelists will be available. So please feel free. They've all said they will be willing to accept emails from folks. So before we wrap, I want to thank the panelists so much for their participation in this webinar. They're working with us over the last few months, both on the issue brief that we wrote and in this webinar preparation. And I really appreciate all the work that they've done. And I want to thank everybody for participating today. And I hope you have the good rest of the week. Thank you.